Of the series, and our topic today is Feminist Global Health as Peace Research, Lessons from Breast Cancer Advocates in Nigeria. Our speaker is Catia Confortini, who is an Associate Professor of Peace and Justice Studies here at Wellesley College, and she's a member of the WCW, Wellesley Centers for Women, Council of Advisors. Catia spent her sabbatical year with us here at the centers last year, and we were so pleased that she's continuing her relationship on our council and being here today and just writing group in other ways. In Nigeria, breast cancer is the most prevalent and the highest cause of mortality from cancer for women. Several breast cancer advocacy organizations have emerged in recent years to respond to the problem, and at the same time, global health institutions and researchers have increased their presence in this as well as other countries of the global south, which have witnessed a surge in non-communicable diseases, including cancer. So today, Catia will discuss a co-authored work. It's a work in progress that seeks to examine global health approaches to the emerging cancer epidemics in Nigeria through a feminist peace studies lens. This is the Baruch Memorial Lecture, and it's named in memory of the former associate director here at the centers who examined the changing role of women in society. So this is just quite fitting with women in the peace movement. If you would, please hold questions to the end. There's going to be some time for some discussion, and join me in welcoming Catia Confortini.
Thank you, Donna, for the introduction, and thank you to the Wellesley Centers for Women and to all of you so many of you that came to hear me talk, and I welcome your feedback on this work, which really has some preliminary ideas on breast cancer advocacy, global health, and peace research. I'm also deeply grateful that this is a memorial lecture for Grace Baruch, but not only because of her research, but also because I learned that she died of breast cancer at the age of 52, which is just about my age. And finally, I'm indebted to the American Association of University Women, who sponsored this project for my entire sabbatical year. I also want to
Could you use the mic?
I have.
Oh, you have a mic.
I have a mic, so should I just speak up a little bit more? Okay. This particular paper draws from two projects. One is an ongoing conversation that I've had with Tina Vaitinen, who's listed there, a colleague from the University of Tampere, Finland, and will form the part of it will form the introduction to a co-edited volume on gender, global health, and violence. And the other is a single author book project on breast cancer advocacy in Nigeria. The ongoing conversation with Tina started actually with our dissatisfaction to the relative inattention to global health issues and critical feminism in peace research on the one hand, and on the other to the inattention towards questions of violence in the global health literature, relative inattention. Specifically, we observed that beyond the metaphorical use of healthy society as a normative goal of peace research, there seems to be relatively little engagement in contemporary peace research with questions of global health and feminism. And simultaneously, critical feminist approaches to the intersections of different forms of violence and health are rare in the global health literature. So we came to the conclusion that bringing together feminist peace research and global health scholarship has the capacity to enrich both scholarly traditions. And this paper represents our working conceptual framework with evidence drawn from my research so far. My argument in this talk is threefold. First, a feminist focus on violence allows us to direct our attention to the embodiment and the enactment of harm, putting the emphasis squarely on the victims of violence. But a feminist approach to violence also rejects the simple gendered opposition between victim and agent, where one who is a victim is also a kind of a passive and without agency of her own. A feminist peace research approach recognizes that victims of violence also have the capacity and inventiveness, the resilience and creativity to live through and despite violence, and responding to violence even in contexts where their agency is restricted. It also looks to uncover the resources, cultural or otherwise, for such creativity and resilience. And third, looking at global health this way may help us develop a different kind of methodology, a feminist peace research methodology, which compels us to uncover hidden as yet not seen forms of violence. In both critical feminism and peace research, understanding the power of critical methodologies is especially important if our goal is to get closer to more just and more equitable societal relations. So this is the outline of my talk. I'm going to give some background on breast cancer in Nigeria and the Global South in general, but my argument hinges on the articulation of the linkages between three forms of violence: structural, slow, and epidemic. And I explicate these different forms of violence and drawing from the practices of breast cancer advocates in Nigeria, I bring feminist insights on embodiment in each of these in order to understand aspects of social and political realities that are not obvious until we look at bodies. And I also want to clarify that I don't understand these forms of violence as separate and discrete levels of analysis necessarily, but they are injustices that are deeply entangled in the actual embodied empirical realities of life and its governance. So I use them more as heuristic devices whose lines of separations are not clean, but which help us probe more deeply into a feminist method centered on body identity and centered on the body, identify strategies to address these violences. A few data. These are data derived by GlobalCan. And by the way, this data, part of the research here has been collecting the data from and analyzing from the GlobalCan report from the World Health Organization. And I've been helped in this by several research assistants at Wellesley, including two that are here. One is Chika Guzier here, and the other is Madeleine Collins over there. Madalena Collins, so thank you. So breast cancer, as you heard before, is the most prevalent cancer for women in Nigeria, as well as the most deadly. It has the highest incidence, almost 51 age-adjusted, 51 people per 100,000 new cases a year of breast cancer, and a very high mortality. And the research also suggests that there has been a sharp increase in the past 10 years or so of both incidence and mortality. Now the collection of data is sketchy in Nigeria because there isn't really a population-based registry, but for all we know, cases of cancer are increasing, and they are increasingly evident and present in society. Now, if you compare this to the global north, these are the first, oh sorry, I did that, so that one. So the more developed regions, North America, for example, there is a much higher incidence of breast cancer, but compared to it, a much lower mortality, right? Mortality is less than, for the mortality, for example, for Norway is about half the mortality rate than as Nigeria. Global health organizations here often refer to the rising burden of cancer in the global south, as cancer is predicted to surge from about 14 million new cases in 2012 to 20 million in 2025, and apparently by 2030, 70% of breast cancer cases worldwide will occur in the developing world, with disproportionately high rates of mortality. I'm going to go to peace research and dig now into structural violence, because structural violence is quite evident in these inequalities, in these health inequalities. For peace researchers, violence takes different forms. It can be a matter of direct physical violence, or that one person or an institution causes to another. But it can also take indirect forms. When the structures are such that they feed into and reproduce violence in particular social contexts, it is possible to talk about structural violence. Paul Farmer, who maybe some people here in this audience may know, describes structural violence as that which is exercised systematically by everyone who belongs to a certain social order. Hence, the discomfort, he says, these ideas provoke in a moral economy still geared to pinning praise or blame on individual actors. In short, the concept of structural violence, he says again, is intended to inform the study of the social machinery of oppression. So when it comes to breast cancer in Nigeria, as well as in the global south more in general, structural violence is the most obvious form of violence. And it is also perhaps implicitly talked about by the global health literature. The absence of adequate breast cancer care in Nigeria must be understood, of course, in the context of post-colonial history, neoliberal economic policies dictated by global financial institutions, and a global health governance system that is subjected to both biomedical and neoliberal demands of governance. These demands emphasize cost effectiveness, liberal individual self-care rather than community, and other harmful practices, I would say. And this, Paul Farmer really noted it 13 years ago in a very important article called Towards an Anthropology of Structural Violence. Structural violence in Nigeria can be seen in the inadequacy of health infrastructure. So there exists today in Nigeria only about 40 oncologists, 40 radiation oncologists. Most state hospitals don't have an oncologist on staff, although federal hospitals do. Nigerian oncologists are mostly radiation oncologists and increasingly surgeons. There's no clinical oncology program or exclusively clinical oncology department in Nigeria. Radiation oncologists and surgeons, and not all of them oncological surgeons, also administer chemotherapy. There are only one or two psycho-oncology wards in the country, or departments I should say, and there are also few trained nurses, technicians, engineers. And a problem of particular concern is the lack of radiotherapy machines. In a country of an estimated between 120 and 170 million people, there exists only 12 radiotherapy machines, of which 9 are linear accelerators. This is the most updated technology. 3 are old cobalt machines. So there is one machine per 15 million people, where the International Atomic Energy Agency recommended ratio is 4 machines per 1 million. At any given time, only 1 or 2 of these machines are working. Or maybe working, and often they lack trained engineers and technicians to fix them, that can maintain or repair them, but also for the unreliability of electrical supply, of energy supply. Further, the Nigerian state does not provide universal health care, and its limited health care plan does not cover cancer and many other illnesses. The healthcare system is essentially a cash and carry, where patients have to pay out of pocket for most, if not all, of their very expensive cancer treatment drugs, or many drugs in any case. The high cost of the most efficient oncological drugs, and often the limited availability of palliative drugs, is another cause for frustration for oncologists, and increasing unnecessary suffering for patients. There is no subsidy, national, international, private or public, for Herceptin, for example, which is a highly effective medication that treats a particular kind of cancer. It costs per dose the equivalent of $2,000. And the prescribed regimen of Herceptin is, if I'm not mistaken, 1 dose per week for 12 weeks to a year. This in a country where the per capita annual income is estimated at $3,000 annually, and over 60% of people live in absolute poverty. So you can see that cancer care is completely unaffordable. Moreover, in a country where women seek biomedical attention, only when cancer has reached a late stage, when all one can hope for is relief from suffering, accessibility to palliative care is critical, and yet oncologists struggle to access opioids, and when they do, they're also unaffordable to most patients. The inadequacy of health infrastructure and human resources, however, is not what causes breast cancer or the breast cancer epidemics in Nigeria or elsewhere. Oncologists and breast cancer organizations in Nigeria respond to the immediate needs they face every day with the resources they have, improvising medicine and care, as anthropologist Julie Livingston put it, referring to cancer care in Malawi. But one must not forget that the cancer crisis in low and middle income countries, this is how they're defined in global health literature, is partially a result of externally imposed structural adjustment programs since the mid-80s, which disrupted health system, as well as a burgeoning pharmaceutical industry that was burgeoning in Nigeria. This crisis is also the result of post-colonial development models that favor rapid industrialization with little to no attention to environmental regulation. All of these can be seen as sources of structural violence, which contribute to the poor outcomes for breast cancer patients and also limit the options for women living with breast cancer. Nigerian breast cancer patients' bodies matter to individual carers, but the system is structured not to care about them in ways that make sense for them. In other words, where global and local economic structures enable the well-being of some bodies and populations at the cost of others suffering, there we see structural violence. So what can an attention to body help here? Breast cancer advocacy organizations in Nigeria are of course painfully aware of structural violence, whether or not they call it such. They are, however, concerned about what it does to women's bodies. So, for example, some breast cancer organizations spend a considerable amount of their time and resources to provide prosthesis, mastectomy bras, wigs, lingerie, even in one case, a cold cap for chemo, which in the US has been approved very recently. In Nigeria, was there a year ago in this organization. So you see here, this is a picture of a group in Lagos, and the women have been given wigs, so a lot of them are wearing wigs and they're posing in this picture for the wigs, and they were very grateful to, I was very grateful that they allowed me to take pictures of them, and they were playfully playing and exchanging wigs with each other. The other is a display that another breast cancer organization called Shebekli, which is run by an oncologist at the Lagos University Teaching Hospital, has literature, but also, pink stuff, and there's a mastectomy, like a prosthesis in view. They have different sizes, different colors appropriate for the women that they serve. These organizations also provide navigation services to the health system, clinic accompaniment, bereavement services, as well as often financial assistance to those in need. In other words, they attend to the bodily and emotional needs of the women they work with, in addition to addressing the financial hardships that result from the unaffordability of care. Some of the younger advocates make extensive use of social media for these efforts, and here the social media analysis has been done by Chika Ebuzie over here. This is a Project Pink Blue that tweets a lot about their activities, and in fact solicits donations for some of the patients that they sponsor through Twitter. and this is a march that they had a walk. So the vast majority of NGOs do a lot of these awareness raising outreach and include walks, bike-a-thons, marches, and they market them as awareness raising efforts about breast cancer. Now, though they are small potatoes compared to the ubiquity of pink ribbon messages, and I have a lot to say about pink ribbon messages in the US, but this is not the US, right? They're small potatoes, these marches, but the pink ribbon is a common sight in the Nigerian urban landscape. But what do they mean in this context? One of my informants says that what they're doing amounts to trivializing breast cancer. What she means is that they're trying to dispel the fear of cancer and portraying it as a disease that one can live through. They do use the battle war metaphor often, but that's for another talk. So they trivialize breast cancer so that women can believe that they can survive it, despite the lack of resources. Further, this awareness raising has a lot to do with exposing also the inadequacies and failures of the state and health system, or the state health system, not directly or confrontationally or either in abstract, but by raising the profile of breast cancer in Nigerian society and politics through making the bodies of women who live with breast cancer visible. Breast cancer advocates simultaneously dramatize breast cancer for their public and global health audiences while trivializing it for women who might be at risk of contracting the disease or who might be sick. So these insights about embodiment point also to the need to understand breast cancer in Nigeria not only as structural, but also as slow violence. So the articulation of this concept comes actually from the environmental studies, from environmental concerns, but helps us also understand how violence impacts bodies. In his book called Slow Violence and the Environmentalism of the Poor, Rob Nixon defines slow violence as a violence that occurs gradually and out of sight, a violence of delayed destruction that is dispersed across time and space, an attritional violence that is typically not viewed as violence at all. Slow violence, he says, is neither spectacular nor instantaneous, but rather incremental and accretive. It takes time to hurt, maim, or kill. So slow violence challenges us to go beyond an understanding of violence as a drama and a spectacle. In this regard, the cancer crisis in Nigeria, as in much of the global south, is to be seen and analyzed as slow violence that is somatized, these are again Rob Nixon's words, somatized into cellular dramas of mutation that, particularly in the bodies of the poor, remain largely unobserved, undiagnosed, and untreated. So going back to Nigeria, the increasing numbers and staggering mortality rates of Nigerians, mostly women from breast cancer, can be seen as a form of slow violence. Only in the last decade or so and a half or so, for example, have global health organizations started to pay attention to non-communicable diseases, including cancer. In the global south, in fact, in the global south, this onsurge of cancer has been contrary to earlier prediction, what used to be termed, or what is termed the epidemiological transition. The theory went that as underdeveloped countries were on path to development, we would see a less and less incidence of infectious diseases like malaria, HIV/AIDS, tuberculosis, and a growth of non-communicable diseases due to increased lifespans and the adoption of Western lifestyles. And so people will live longer and have a higher chance of contracting, of getting sick with cancer, and start also dying less of infectious diseases. What instead has happened is that both things have happened. So people are continuing to die from infectious diseases, but also increasingly die or get cancer. So the small number of oncological and technological personnel are scrambling with little government support to diagnose and treat increasing number of cancer patients, while they're also treating great numbers of infectious diseases. In the meantime, global health foundations and donors also tend to skew away from breast cancer cares and technical assistance and skew away from breast cancer care, while they direct their attention and technical assistance more to communicable diseases and now cervical cancer. Cervical cancer has kind of entered the equation a little bit surreptitiously because it's associated to the HPV, so to a viral infection, and so can be treated with a vaccine, and it's supposedly easy to treat. So in Nigeria, one of my interviewees, Dr. Okoye, actually complained that her organization tried numerous times to get the World Health Organization's attention, with no results. And today, WHO doesn't have any breast cancer program in Nigeria. The World Health Organization's Department of Non-Communicable Diseases, Disability, Violence, and Injury Prevention has only 2 people that are in charge of cancer. And neither has the Bill and Melinda Gates Foundation, whose presence in the country is otherwise impressive, given any money to breast cancer. And only through the pressure of one former officer of the foundation that I interviewed, they inserted cervical cancer, and she did that through the HPV angle. So there's very little funding coming from outside organizations for breast cancer, or even cancer in general, other than cervical, with the exception of small funding from the Union of International Cancer Control. So this points to the invisibility, in a sense, of breast cancer in Nigeria. Slow violence, though, also helps us or forces us to foreground questions of time, movement, and change into the equation. Right? One explanation that global health organizations give for the deadliness of breast cancer is that in Nigeria, women present at a late stage. So women go to seek biomedical attention when their cancer is already metastasized or very late stage, with few options for treatment. And so they say because they arrive at the late stage, they die in such great numbers. They get to the doctors too late. And the key to better survival rates is early detections, because there are better options for treatment. But a focus on early detection only tells part of the story. Right? It does not explain, why women get the disease to begin with, because that's the job of primary prevention. And also it doesn't explain, it doesn't help decrease the suffering of women with advanced stage breast cancer. So these women's bodies are in effect invisible, as is the slow violence of breast cancer. So here I want to bring in some feminist and Western feminist and critical interventions, not only in the literature, but also feminist activists that work on breast cancer with more critical lens. These activists in the global north warn us to be skeptical of this myth of early detection, because there are types of breast cancer that are deadly even when detected early. Feminist investigation again points to bodies, because of the conspicuous absence of research research on breast cancer in African women and women of African descent in the global north, as well as in the global south. We don't quite understand why breast cancer incidence in these women is rising. And also, excuse me, we don't quite understand why the mortality is so high independently from late stage presentation, or higher, even when detected early. Breast cancer advocates in Nigeria, on their part, call, for example, for clinical trials to be undertaken in Nigeria as a way to both increase our understanding of the disease and its causes, and also a way to partially address the inadequacy of resources and treatment options for women at all stages of the disease. And more recently, as a result of the pressure coming from organized metastatic breast cancer advocacy organizations, as well, some global health organizations and some pharmaceutical companies through the Union of International Cancer Control have started funding projects in Africa directed to metastatic patients. So two Nigerian organizations were funded through this program. Project Pink Blue in particular used and this is the program, this one, okay? Project Pink Blue in particular used the UICC funding to establish also a patient navigation program coupled with nurses training in palliative care to focus on the alleviation of suffering for those women who are made invisible through an exclusive focus on early detection. What time is it? I will skip this part and go to this one. Actually, this one, sorry. Okay. So this brings me to this question of invisibility brings me to the notion of epistemic violence. Epistemic violence is a phrase that I borrow from post-colonial feminist scholar Catia C, and it is essentially the violence of knowledge production. Basically, the harm inflicted through discourse. It includes the stereotyping, distortions, and generalizations about Global South women's condition, as if they were all homogeneously belabored, lacking agency and needed saving. It is the violence of silencing. Epistemic violence is helpful conceptually as well as methodologically because it compels us to look for silences, to identify violence done when our conceptual and discursive frameworks blind us to alternative worldviews and to those who espouse them. In peace studies terms, epistemic violence happens when we other those alternative views without engaging them, when we kind of block them from our view. One way in which epistemic violence happens in Nigeria around breast cancer is through the assumptions made about the reasons why women do not seek biomedical help early. At international conference like the World Cancer Congress that I went in Paris, that I went to recently, the ubiquitous word there was stigma. Stigma is what makes women go to seek biomedical care late. And it's never quite clearly defined. One doesn't know that if it's stigma about cancer, is it stigma about the women, is it stigma about cultural beliefs on the causes of cancer. It's kind of a wishy-washy or a catch-all phrase, right? It's a catch-all phrase that reflects some assumptions about Nigerian and more in general African cultures as other, static, inferior to biomedical knowledge. The global health establishment assumes that traditional cultures or beliefs are harmful and hence source of violence, but fails to look introspectively at itself as a culture. And relevant for my argument here is that relying on an ill-specified notion of stigma is representative of epistemic violence to the extent in which patients' experiences are silenced and assumed a priori to be harmful because at odds with the rational, biomedically compliant behavior. Right? They think they are irrational because if they were rational, they would go to the doctor really early. And the other assumption is that by traditional healers or spiritual healers cannot possibly match the superiority of biomedical knowledge. Now, sorry, let me see. So while biomedical experts silence the voices of patients themselves by assuming that an ill-defined notion of stigma and related othering of Nigerian culture is responsible for a late-stage presentation, for breast cancer advocates in Nigeria, the picture is a lot more complex. Focusing on the embodied realities of patients, Nigerian representatives of breast cancer organizations, as well as Nigerian oncologists, often talk about culture or cultural practices, right? They do cite that there is a lack of awareness of biomedical knowledge and an excessive reliance on traditional healers or religious practices, and these are cited as reasons why people delay seeking medical help. But the interviewees also recognize the wider social, political, and economic barriers to early detection, citing economic strains, perceived lack of community or family support, difficulty in reaching hospitals. You can imagine that in a country where there is one or two radiotherapy machine working and you're in the north and the radiotherapy machine is the only one that's working is in the south, it's a big country. All of these, in other words, late-stage presentation for my interviewees reflects a number of entangled systemic constraints to women's agency. Primarily are economic barriers, primarily among them. For example, several of the women of the patient group that were wearing wigs last time, several of them cited to me, told me that as soon as they were diagnosed with cancer and had to take time off work, they were fired. Many others cite economic hardship as reason for lack of follow-up to treatment. So they started because they found some money to pay, and then they have to stop it because the money is run out. And then you have to consider that biomedical, when one is run out of alternative, traditional healers are a lot less expensive. And, why not? I don't have money to do the other stuff. Because here I'm not advocating necessarily that alternative treatments to conventional Western approaches work better. I'm not saying that. Because we know that biomedical treatment affords the highest survival rates and are not without critics, and they have not necessarily progressed us into a really better understanding of the disease. But, as anthropologist Julie Livingston says, while cancer with oncology is awful, cancer without oncology could be obscene. Mm-hmm. But there is more to spiritual healing than cost or irrational or unscientific and unfounded faith. And breast cancer in Nigeria, advocates in Nigeria know that. So this is a flyer that the breast cancer organization called Chebekli, which is run by an oncologist at Luth, the same one with where the prosthesis was displayed. She runs a retreat at a spiritual religious camp that belongs to one of the mega churches in Nigeria. She runs a retreat there, a spiritual retreat. Her name is Dr. Salako, and I think that what she told me about her practice, both as an advocate and as an oncologist, is well worth quoting. So, she says, for her, management of cancer is holistic. You have to do the treatment, you have to talk about diet, you have to strengthen the emotional aspect, which is linked strongly with the spiritual aspect. During moments of fear, how you respond is based on what you know. You may decide to get scared. You tap into your spiritual strength. It may be a song, it may be a verse, it may be... We can't deny the fact that people believe in prayer, in fasting, people cured by miracles. So I have an acronym in my head, the gift of survivorship. G is for God, I is for information, F is for food and fruits, treatment, T is for treatment, and serenity. In other words, she has this holistic understanding that sees spiritual well-being and support as part of the continuum of care, but in a very embodied way, and without demeaning or without discounting what her patients' needs are or fears. What a focus on embodiment and epistemic violence tell us is first to pay attention to women who are often not included in the decision making about what is best for our bodies. And this is true here and in Nigeria. Notable at the World Cancer Congress in Paris, for example, was the near absence of patients' voices, almost, from the vast majority of panels. In particular, in Nigeria then, and as in other post-colonial societies, attention to embodiment means bringing together and paying attention to the wisdom of not only different bodies, but also to different spiritual practices, different understandings of mind, body, soul relations that come from Nigerian women. For all the breast cancer support, for breast cancer groups that I came in contact with in Nigeria, the spiritual element was strongly present, even as some drew sharp distinction between traditional healers and Christian healing or churches. Embodiment, in other words, allows us to understand the coping mechanisms that women employ to live with and through breast cancer as a form of agency. So I've reached my conclusion here, and I'm drawing again on the work of Rob Nixon, because Mandy Donahue, who does work on peace women or women peacemaking in Northern Ireland, she takes his conception of slow violence and turns it on its head and talks about slow peace. Mm-hmm. So she says that in just juxtaposition to slow violence, slow peace is similarly out of sight, concealed in the banality of the everyday. It is not focused on one dramatic event, but rather happens across communities and across time slowly. And finally, just as slowly, it is contributing in an accretive way to the strengthening of communities. I like to think of the practices of breast cancer advocates in Nigeria in a similar way. Through their focus on the embodied everyday needs and embodied voices of women with breast cancer out of sight from the world of global health, through their ongoing banal work of providing wigs, hosting spiritual retreats, blowing the birthday candles for yet another year alive, walks and marches, raising funds, reaching out to churches and markets, they contribute in an accretive way to deepen our understanding of breast cancer as violence and to amplify the voices, wisdom, needs, and agency of women living with breast cancer in Nigeria. As for peace research, because that's my job, This work points to the need to go beyond the metaphors and recognize concrete embodied health as pivotal to the study of peace and violence. In this regard, this work is part of an emerging movement to make feminist approaches to peace research visible, not only as a question of women, but as a wider question of the hierarchies between masculinities and femininities. After all, despite decades of feminist work, and you all know something about it, the patriarchal hierarchies in the field of peace research continue to render feminist perspectives on violence irrelevant for the disciplinary imagination. Consequently, also feminized questions such as global health, public health, sickness, corporeality, and sexuality become overshadowed with the more masculine realms of peace and violence, armed conflict, and war. Since health is instead always about the politics of gendered and sexualized bodies, I believe it is crucially important for feminist peace research to engage with the global health scholarship more directly and explicitly than before. In the context of health, Peace research can provide nuanced analysis of violence in particular empirical contexts, whereas the transnational world of global health can widen the horizon of what it means to study violence, peace, and justice in the embodied everyday. In other words, feminist peace research can make for better global health.